Hello, everyone. I'm JD Osborne, Vice President of Sales for Corneogen. Thank you for participating in today's course entitled Advanced DMEK, a roundtable discussion on complicated cases. We're pleased to offer a third webinar featuring our terrific panel of DMEK experts, Dr. Nicole Fram, Dr. Terry Kim, and Dr. Elizabeth Yu. Some of you may have seen our first two Advanced DMEK webinars, and if you haven't, please give them a view. You can find them on our education page of our Corneogen website. Truth be told, these webinars went so well and we had so many questions that we just couldn't get to that we decided to get our esteemed panel of surgeons together again to answer your questions and to talk about the nuances of the DMEK procedure. So buckle up and enjoy the many tips and pearls that our panelists are able to share tonight that will make the DMEK procedure easier during those complicated eyes. During today's webinar, you'll see a few real-life DMEK complex cases as narrated by one of our surgeon panelists. Learn about what you should consider before proceeding with DMEK on a complicated eye. We'll answer your pre-submitted questions and ask our panel any new questions that you think about challenging cases you've experienced. You can submit a question anytime during the webinar by using the questions box in the upper right-hand corner of your screen. Click on the plus sign. It will open a text box for you to write and send your questions or comments. We'll use the last 10 minutes of the webinar to answer any final questions you may have. We'll do our very best to answer as many of them as possible during our allotted time this evening. Please know that Corneogen can further assist you with DMEK. Please contact us at info@corneogen.com, and one of our experienced surgical product specialists can provide you with the tissue and tools, including coaching you through a one-on-one DMEK wet lab as you practice the techniques before your first or your next DMEK procedure. Now, let me tell you a little about today's panelists. Dr. Elizabeth Yu has been a partner at Virginia Eye Consultants since 2014. She also currently serves as secretary and member of the executive committee of the American Society of Cataract and Refractive Surgery. Welcome, Dr. Yu. Next, we have Dr. Terry Kim, who is a professor of ophthalmology at Duke University Eye Center, where he also serves as principal and co-investigator on many research grants. Welcome, Dr. Kim. And last, but certainly not least, Dr. Nicole Fram is the managing partner at Advanced Vision Care in Los Angeles. In addition, she is the clinical instructor of ophthalmology at the Stein Eye Institute of UCLA. Welcome, Dr. Fram. It's good to see all three of you join us now. Dr. Fram, Dr. Yu, quick plug. I really enjoyed your podcast, The Quicksand Chronicles, as I believe you just completed episode 11.
Yeah.
And I am still awaiting Dr. Terry Kim as your distinguished guest.
Oh, that's coming up. He doesn't have complications. Come on.
Don't worry, Dr. Kim, they'll get to you eventually. And now we're going to have just a few poll questions and to learn a little bit more about our audience experience level this evening. We've developed a few poll questions to learn a little bit more about you. During each poll question, you'll be able to click on the answer that best reflects your experience level. So first up, we have, how many DMEK procedures have you done to date? You can see the answers here. Please click one answer. I want to get started. 1 to 10, 11 to 29, 30 plus. Just a few more seconds now. And let's see the results. Okay, so a good mixed bag there. Again, we've got a handful that have just getting started, which is awesome. We have about 37% 1 to 10. And 11 to 29. And then we've got some good experienced surgeons on the broadcast. Thank you. Next question. What is your current percentage of DMEK versus DSEK? Is that 10% DMEK to 90% DSEK? Or more 25-75 split, maybe 50-50, more DMEK than DSEK, or majority DMEK, and those DSEKs when you have to. We'll give it just one more second here, and ready for the results. There you go. So the majority is mostly DMEK with about 10% DSEK. We have a good bit, again, looks like they're just getting started on DMEK at 25%. Next question. How are you currently receiving your DMEK tissue? Goiter preloaded glass cannula, preloaded Jones tube, another preloaded device, or not currently using preloaded DMEK? So waiting for a few more results to come in here. And the results. Vast majority of the goiter preloaded. We do have the Jones tube and not currently using preloaded DMEK. Interesting. And we have one final question here, as if you're not probably a little bit fatigued from this question. How has COVID impacted your current transplant volume compared to pre-COVID levels? I'm back to 100% transplant volume, 2019 pre-COVID levels, 75%, about 50%, or 25% of pre-COVID transplant volumes or less. And the results. So almost 50% back at 100% transplant volume. The other 25 to 50%, and also a good bit at 75%. Thank you. So before we hop into some surgical videos during this webinar, we did have a few pre-submitted questions that we kind of wanted to warm up with. We plan to weave in all of the pre-submitted questions, and thank you for doing so and submitting those ahead of time. So to get started, I will throw this question out to the panel. Do any of you have any DMEK tissue warming protocols prior to a procedure? Dr. Kim says no. Dr. Yu with the head shake. Dr. Fran.
So I always have been taught to take out the tissue 45 minutes before so it'll cool to room temperature, but I don't warm the tissue. I just kind of take it off ice because that's when Optisol becomes most effective. So that's what I do in my practice. So if I know my DMEK or DSEK's coming up, I'll say take the cornea off ice, I check it just to make sure that we're on track for the second room.
And the other thing I tell my nurses is to tip the bottle so that it is oriented with the tip on the bottom end, so the graft tends to float towards the tip of the goiter cannula, within the goiter cannula, because you don't want it to be on the edge. So when you open it, it will accidentally come out.
Absolutely.
Good pearls there. So next we have Dr. Yu. I'll direct this one towards you. Do you have any specific donor criteria for your DMEKs, especially with these complicated eyes?
I definitely think that I prefer to have tissue that is a little bit of an older donor. So I'd say, whereas before it was 65 and older, I'll go down to about 60 years old. But sometimes I will ask for a smaller donor size than I normally would. So instead of a 7.75, I may even go down to a 7 1/4, just depending on what I'm seeing going on in the eye. Like if, for example, if there is a tube, even if it is a shorter tube, just so that I have less chance that it's gonna actually engage the tube during the process itself. And obviously I'm looking for synechia and other things that would concern me as to whether I would pick a DMEK versus a DSEK for the procedure itself.
Dr. Yu, you actually just ate into my next question. So I'll ask Dr. Kim and Dr. Fram, as far as that DMEK diameter, do you kind of have a default size, or like Dr. Yu said, maybe for some of these more complicated cases, you would adjust accordingly? Dr. Fram.
So I'm pretty much at 775 all the time. But I think Liz brings up a great point. If there's a lot of peripheral anterior synechiae or a tube, even if you trim it, it's better to, be more central. And I know, Garrett Mellis has taught us that we don't even need the whole DMEK, we can use half of it. So if you want to go smaller, and it helps with centration issues also, if you're slightly decentered, you have a bigger desma rexus, it's still going to work.
I do a default, and actually probably a little larger than these gals, and I do an 8mm graft. And we've done enough of these, whether it's cataract or DSEK or DMEK, you have such a range of corneal diameters, and I've played with 7.5, 7.75, and I just decided on 8.0. But I also agree with Liz and Nicole. I mean, look at the patient. They may do better with a smaller graft, or they may do better with the slightly larger graft. Some folks go 8.25. So
right.
Customize it as needed. But
yeah, you got to look at the white to white, because sometimes I'm like, why did I go so small?
Yeah.
Absolutely. Thank you all for your feedback. Now, I was really wondering when to put this question in, but I want to ask it at the front. In your opinion, what is the best way to master DMEK? Dr. Yu?
Wow. So I think understanding the dynamics of anterior chamber maintenance is going to be really helpful. If you are a DSEK surgeon, it's the exact opposite. Instead of a super deep chamber, you're going to have a super shallow chamber. So I would start with non-vitrectomized eyes, post pseudophakics, and I would stage it. I think that it can become more challenging with all the additional variables. So that would be my recommendation.
Dr. Fram?
Yeah, I fully agree. When I started doing DMEK and trying in 2012, and we didn't truly understand the fluidics and the uric technique of shallowing and tapping. So once we figured that out, so once you figure out that you don't need to hit it really hard and it's little taps and it's a dance of shallowing and tapping, that really takes you to the next level. And then picking the right patient. So I think only with experience do you figure out, I'm just going to go with a nanothin DSEK here, or I'm going to go with a DMEK. But yes, avoid post-vitrectomized eyes. I always like to stage cataract and DMEK. I just find it more controllable. So I fully agree.
And Dr. Kim, I'm not going to tell our audience tonight about your first couple of DMEKs, but how exactly do you suggest mastering the DMEK procedure?
Well, I mean, we were very happy doing DSEK with our ultra and nanothin grafts. They had great outcomes. And really, it's actually because of our fellowship training program that motivated us to start doing DMEK. And I was surprised myself as I continually increased the conversion to DMEK versus DSEK, because I really reserve DSEK for those more complex eyes with the PAS or maybe dense, there's a lot of corneal edema where visualization may be difficult if it's an anterior chamber IOL, maybe vitrectomized eye. But for the straightforward DMEK in a pseudophakic eye or the straightforward DMEK triples, we get a lot of Fuchs dystrophy here. I'm really primarily doing DMEK. I think they hit on two very key things when you're doing DMEK surgery in terms of mastering the technique is understanding anterior chamber fluidics and also controlling your anterior chamber depth. I think if you can do those two things, you can start to understand how DMEK works. And I strongly recommend all our fellows and anyone learning this to look up Michael Strako's video, Straiko, on YouTube. It's free. But what I like about his tutorial is he also has a diagram showing you what the anterior chamber fluidics are doing when you're doing certain maneuvers, so you can understand, because it can be very counterintuitive to some of the things you do in DSEK.
Mm-hmm. Absolutely.
Well said. Thank you each for addressing some of these pre-submitted questions. I assure you I'll get a little bit more challenging as the webinar goes on. Now, unfortunately, I'm going to disappear for a bit. I'll join you again when it's time to ask some more questions. In the meantime, Dr. Yu, will you speak about a recent complicated case that you had experienced?
Yes, actually, I'd love to get Terry and Nicole's advice on this. So, like I mentioned before, and I'll just start the case. Well, while it looks like it's a capsulotomy that may not be continuous, as you can see here, it is continuous, just a little oblong. So 5.5 millimeters in the longer direction, 5 millimeters in the shorter direction. So after I did a nice 8 millimeter strip, as you can see, I also used my IA to kind of roughen up the deep stroma, but I just didn't even think about it. And I used a one-piece lens with a gummier hydrophobic acrylic material. And as you can see here, while this is a relatively normal eye, minus the fact that the myostat or myocol is not working super well, and I didn't even give that any consideration, but every time I try to shallow this lens, even though I've oriented the haptic in the proper meridian, just because of the material itself and the eye being what it is with the AC, I can't get it quite shallow enough to make it easy for me to unscroll without the IOL coming up. And I didn't want the actual optic to pop out of the bag. So as you can see here, this is a fine dance. And what I've turned a routine triple case into a more complicated case for myself. And so I tried multiple times actually to find that perfect balance where I could just get the IOL to not move much. And then at the same time, you know, I wasn't quite ready to inject air in between the space, but I was getting in between the scroll to try to kind of unravel it a little bit, because as you can see, it was a bit of a tight scroll on top of that, just a 775, you know, but it looks for some reason a little bit larger in this eye, just a relatively smaller eye. And eventually, once you can kind of get it where you can keep it still in one meridian, you can open it up, but you know, I'll just go ahead and let this run. You guys get the gist of it. And it just took little bits of let me release, let me release, let me just try to get it to center. And I was willing to have a slightly decentered graft if I could just get this thing to open.
Right.
So, you know, Terry, Nicole, I mean, help a sister out over here.
Yeah. This is Cindy's help. Yeah, I mean, the thing is that I've had this happen where I used to use, you know, tropicamide, phenylephrine, cyclogel before my cataracts, and then I would do the cataract surgery. I make my Rexus 4.8 intentionally because I don't want the optic coming forward, and I go to put the myocol in, myostat, whatever I have, and the pupil just won't come down. And so in that scenario, I mean, this is amazing that you even were able to get this open, because we're really using the iris, bouncing on the iris to unfold the tissue and shallowing the chamber. So I sometimes will put them in the post-op area and do a couple cases and have them come back in. But I've changed my pre-op regimen because of this exact scenario. So I will just give them 1 drop of phenylephrine, and then I use my epi sugarcane during the case to do the cataract. And yes, you know, you're going to deal with floppy iris or other things, but I'd rather control the iris with some hooks intraoperatively than have a pupil that just won't come down.
Yeah, I'll echo what Nicole said. I mean, we had this issue when we do the full round of dilating drops, so we've cut it down. Now, one of the side effects you'll get from that is during the cataract surgery, your iris will behave like a floppy iris pupil a little bit. But it's usually something that all of us can get through without having to put in a pupil expansion ring. Typically, we want to do these cataracts a little sooner. So my DMEK triples tend to be, you know, maybe 1 to 2 plus. Eventually, sometimes I have a dense lens combined with a Fuchs, then I'm doing a combined case where I'll make the Rexus larger, but I like to make it around, you know, 4 to 5 millimeter range if I can. And I will also I usually go with myocol first, but if that doesn't work, then I'll go ahead and ask them for some myostat as well. And sometimes that combination will help bring that pupil down.
Yeah, and then irritating the iris, trying to get it to come down. But yeah,
Right.
this is
Tickling it.
happening. Yeah, just a little tickle. But this has happened more than once to me. And there was a couple years way back when we were just using epi sugarcane. Like we weren't even dilating people because we wanted to do things faster. So
Right.
it is possible to not dilate them at all. But that does challenge, make your cataract surgery a little more challenging.
I know we have a lot of. Go ahead.
Oh, no, Liz, I think what you did great there was, obviously the concern is the trauma of the lens against the endothelium there. So trying to move it to the side where you have some iris and try to unfold as much as you can peripherally, and avoiding really hard taps right in the middle where the graft may constantly hit the IOL to avoid endothelial trauma. So you did a great job of unfolding it.
Yeah.
So question to you guys, I know we have to move on, but so it sounds like, are you guys not blocking your DMEK cases either?
No.
I do block.
I block.
I just do topical.
Got it.
Yeah. So
Okay.
with the block and epi sugarcane, it's fine.
Mhm.
But that's probably why, because we block, Liz, it's probably why the pupils aren't coming down as well as
Especially
others.
these light, yeah. So I turned a
strongly-
routine case into a complex one.
Yeah, I would recommend, these patients tolerate topical anesthesia just fine. I do use intracameral lidocaine with these cases. That together, they usually don't have any or minimal discomfort during the whole procedure. So try it. I think that'd be a good transition, and it would avoid this scenario, I think.
Right. And if they start acting up, then we can do a sub-tenons.
Right. Well, I'll tell you, I normally do a preloaded 3-piece IOL from BVI, and it's a little bit more rigid. It's the 3-piece former like Hoya material. So it's a little bit not as gummy, so it's not as malleable. And that is also, every little variable can really synergistically add to the complexity of the case. So that's just another consideration, which I just didn't think about, because you do enough of these and you just figure, oh, I'm fine. And then this happens, and it's a very good reminder.
And, just to clarify for the audience, I think when you're injecting your myostat or myocol with the cannula, I just go into the para and make sure I pass the little angle part of the cannula, because otherwise you have limited mobility with that cannula in the anterior chamber. And as I'm injecting it, I'm stroking the iris,
Yes.
and I try to go through the other para too. And you'll see that really helps constrict
like a little
that pupil.
flutter. Yeah. All right.
Great case. This is going to happen. So
great case.
Absolutely. Thank you, Dr. Yu. So let's read through some of the questions that were submitted by our audience members when they registered, and a few actually just came in live here. So Dr. Yu, this first one's for you. For DMEK with combined phaco, do you have a preference with staged versus combined? And I think to maybe add a little bit more direction to this question, what would you say your experience early on versus as you became more comfortable with DMEK?
So great. I always did staged. If I was going to combine it, because I knew there was corneal edema, I always did kind of that 50 to 60 micron nano thin, ultra thin DSEK combined with with my cataract surgery, because of that nice deep chamber. Once I became very comfortable with just DMEK alone, that's when I started combining it. But I did use that 3-piece IOL. So I would say start staged before you move in the direction of simultaneous triple. Your fluidics, just having the fibrosis and the IOL stuck together in the bag, it does make a big difference, especially with having a constricted pupil for the duration of the case. It makes a big difference, as you just saw.
Dr. Fran, what are your thoughts on that, combined versus stage, maybe early on and then, further in your progression in DMEK?
Yeah, I fully agree. I think now I can do a combined and know all these issues with dilation and on all of this. But I think in the beginning, my first combined case was very high myope, and it was really hard for me to understand the fluidics to shallow the chamber. So I think, really avoiding high myopes if you're doing a combined is another pearl there. But I have no problem with a stage. And sometimes patients appreciate that you're just going to do the cataract, give them a chance. And if they don't do well after that because of scattering and goutte, then you'll move to the next step. But if they have significant corneal edema and you think you can see through it, combined is a great way to go. You just want to wait till you're through your first, 20, 30 cases.
Dr. Kim, this question was directly towards you. When doing a combined DMEK case, do you do anything differently with your pre-op dilation regimen to prevent any issues constricting that pupil?
Yeah, like I said, I have decreased my dilating drop regimen to just one. We have a combined bottle that has the tropicamide, phenylephrine, and the cyclo in it. So instead of doing 3 rounds, which we used to do, we just do 1 round, and that will help quite a bit. And I just want to add my share of the combined versus staged. I think it's fine to do them staged. Doing the cataract combined with the DMEK, there is a learning curve in terms of doing that smaller capsulotomy or capsulorhexis and trying to get a lens out through there. So that's why I say, I have a lower threshold for going ahead and taking these folks and doing the cataract earlier when it's softer. But the other thing is, be careful if they have any microcystic edema that's going to throw off your IOL calcs. You want to do the DMEK first there, get rid of their edema, and then get a much more accurate calc so you don't have a refractive surprise. And you know what? Doing DMEK in phakic patients is actually easier than doing in pseudophakics because you have a shallower chamber.
Right. You just don't want to use gas in a phakic.
Gas as in SF6.
Yeah.
Gotcha. Dr. Fram, when using MyoCal or Myostat during DMEK, how do you minimize those pesky bubbles? Looks like we've got that question a few times. So have you ever run into that or any pearls?
I got some tips on that. So we use a solder cannula, so it's not the 27 gauge angle, and that helps a little bit because it's a little more narrow. We also put a filter on, so by putting a filter on, and then always before you go in the eye, you should be testing to make sure it's on tight, because if anyone's harpooned anything, and then I just always squirt a little bit out before I go in. Even with your best scrub techs, you may get some bubbles.
Any other pearls from the group there on those pesky bubbles, specifically for MyoCal or Myostat?
I think it also will happen sometimes when you're stromal hydrating the wound, and sometimes you'll get a bunch of bubbles in. I think the filter for the MyoCal Myostat is key. And then, you can just go in with your IA tip and just aspirate if you do to improve your visualization before you go back and inject the MyoCal Myostat.
If you have a lot of teeny little bubbles, make a big bubble so then they all come together, and then get the big bubble out.
And Dr. Fram, what was the name of that cannula specifically you just mentioned?
It's
solder?
the BVI solder cannula.
Can you spell that?
SAUDER.
Got it. That actually was a live question.
Okay.
An awesome job with the spelling. Dr. Yu, back to you. And this, I actually love this live comment, especially considering your video with that larger pupil. Kind of tying the two in, this more of a comment says, I would like a simplistic explanation on how to resolve an air or gas bubble when it slips from the AC to behind the iris or the posterior chamber.
I can start with this one. I mean, obviously going to be a bigger risk when the pupil doesn't want to come down. And this is for either, any EK surgery that you're doing. Now, obviously, when it's going to happen in general, it's because it's after you've got your donor disc in, right? And you're putting your gas in. Couple of things that I do, I generally, so if my PI is inferior, right? So I'll either go temporal, aim towards the superior iris a little bit, or go through my superior paracentesis, but I'm aiming towards getting right under and under the graft itself, and making sure that I'm actually aiming towards the iris and not right into the center or directly under where the pupil margin could be. And in a DSEK, it's way easier because you can have a deeper AC. In a DMEK, it's not so bad as long as there's not too much positive pressure in the eye. So I try to make certain that the pressure in the eye is relatively soft too.
Dr. Kim, that air bubble behind the iris, can't get it out. What do you do?
I will tell you, I mean, Liz made a great point of making sure that cannula is not near the pupil edge. You don't have to go that far with the cannula. I think two things are key is, one thing is when they hand you the cannula with air, a lot of times folks just go right into the injection, and that rubber stopper in the cannula, it's sticky. So I always make sure the residents and fellows push a little bit so you break that little seal, so that's going to be a smooth transition with your plunger, okay? And then what I tell them is once they sneak that cannula in between the iris and the DMEK graft, all you have to do is make sure you're obviously under the DMEK graft, and you don't have to go all the way out to the pupil margin. Remember, in these cases, your pupils are usually pretty small. Just go enough that you're past the graft. And what's key is, again, that slow injection. A lot of times I see this rapid injection. That's when you can also have the displacement of the DMEK graft, which is not the end of the world. And if it's mildly decentered, leave it alone. You know, enemy of good sometimes is perfect. As long as you're covering that visual axis, you'll be fine.
Dr. Fram, have you ever had that behind the iris?
Okay, so I need to talk about this because let's just go back to DSEK. When I first started doing DSEK, I would get the graft in. I was so excited. I just like, bam, I put so much air in the eye. It would go behind the iris, and I would go up to Terry or go up to like Tony Aldave and be like, why does it keep doing that? And they're like, I don't know why you're having that problem. And Terry's point about just putting a small air bubble in first and then watching it grow slowly after is so important. And I will sometimes just use a TB syringe at first just to get the bubble, you know, just a smaller bubble, like 3 millimeters where you want it. And then I fill, and you'll show this in the next video, from the side to really get that big fill. So these are really good tips in order to not get air behind the iris. Now, if you get air behind the iris, the key is what Liz said at the end, which is I go at the main incision, I cut the suture out, and I decompress the whole eye, and I get it back to a normal pressure with BSS, and then everything comes forward, and then you can start over. But I find doing maneuvers and pushing down on the iris and then hitting my graft, it's never good. And so I just go to my main incision and push down and try and get all the air out in that way.
The other,
and then you
I think,
over.
Oh, go ahead. Yeah. I was just going to say the other scenario, JD, where this can happen is actually on that post-operative day 1 visit. So you may be fine during surgery, and some of these patients will come in partial pupillary block, or some of that air has gone behind the iris, so you have this pupil part of the iris that's plastered against the cornea. And there, I think it's important, you want to lower the pressure, which may mean losing some of the gas that you put in, and then dilate the pupil, have them flat in your clinic lane until you see that bubble pass, and then you know that you're going to be at much less risk for having pupillary block.
Dr. Yu, you look like you wanted to get in there.
Well, I mean, that was and obviously cortopic pupils where you've got like a large, iridectomy, or there's, damage that has happened from a post-traumatic eye. Those eyes, it is very easy for air and gas to slip under. When you're going in too, I mean, before even the slow injection, just like Terry said, I always hold the plunger back just a little bit, because sometimes air just slips in from just like the negative suction into the eye, and it can already go behind the iris, even if it's a little bit or between the graft and the cornea, which is what you don't want. But you have to get the eye softer if possible, because if you've got a bunch of gas or air behind the iris, that the positive pressure that's coming up can be very, very difficult to manage. So the first thing is, switch to a BSS cannula, go in. If you can, take out your suture, make it so you have at least 2 millimeters to work with, where you can almost press. And sometimes you have to go and suck out some of the gas and get your pressure normal. Come back out, release any of the gas that you've sucked out, and then go back in and allow the BSS to break that iris that's been collapsed forward. Because once that iris diaphragm collapses forward, it keeps wanting to collapse forward, even within a softer eye. So the first thing is you have to break that, and you have to get that pressure normal, just like Nicole was saying.
That's all great feedback. Thank you, guys. But Dr. Yu, since you touched on something, I'm going to go ahead and throw it out there. With a chorotopic pupil, do you guys just do a DSEK, or would you still do a DMEK? Dr. Kim?
I think it depends on the amount of chorotopia, but if it's a fairly large and eccentric pupil, I probably have a pretty low threshold to just going and converting to a DSEK.
Dr. Fram, what are your thoughts?
I just had this the other day. I moved the pupil using a 25 gauge diode intraocular cautery, and then as long as there's enough pupil to work with, do a little cerclage on the other side to just bring it a little more central. So I've done that, but there's nothing wrong with a nano thin or ultra thin DSEK in a complex eye. There's nothing wrong with it.
Dr. Yu, anything else?
Actually, it's a question for Nicole. I'm always so nervous about messing with the iris because of the pigment release and the potential fibrin. So like for DMEK, I just won't, I'll do anything I can to not release pigment. Like in which eyes do you say, well, this may be okay, you know, it may just be because, you know, of your masterful skills. I mean, I would switch to DSEK, but, you know, because you're talking about diathermy and
you kind of have to make, right. I mean, you kind of have to make a decision before you get in there, right? Because we can't just swap out DSEK and DMEK tissue. Those were the good old days. But, you know, so I make the decision beforehand. So if it's just a little bit decentered and I think I can do it with the diode, you know, with the 25 gauge diode cautery intraocular under OVD at a setting of 10, then I'll do it that way. But yeah, I think that if it's a big pupilloplasty, I'm not going to want to do that at the same time as a DMEK. You're absolutely right.
And
I think
question, Terry Kim.
No, I was just going to say Liz brings up an excellent point. You know, I think especially early in the learning curve when you're doing DMEK, I think the tendency is to tap really hard and you will start seeing pigment release, and that's what you really want to avoid because that will lead to fibrin formation. So I think the key is when you start, and you're not going to be able to avoid this from happening. Even just in some patients, when you tap lightly, you'll start seeing pigment release. And what I do in that case is I'll go ahead and take my BSS cannula and inject BSS and burp the para or wound to just get that pigment and the beginnings of any inflammatory fibrin out of the eye. Because if you don't, what will happen is that that graft will get kind of rigid and you'll start getting kind of like origami folds in it that can be hard to kind of release. So you want to avoid that scenario if possible.
Did you just plan, did you plan that? Because that's really something, TK.
Eric is really trying his best to get on the next Quicksand Chronicles.
Really, I mean, he just origami'd us. Like, that was good.
And we won't tell him it's a podcast and they can't see his origami. So we've really got the questions flying in, guys. As always, you're ever so engaging. And so next, we'll have Dr. Fram present a recent case that included a DMEK under a recent DSEK procedure. Take it away, Dr. Fram.
Okay, great. Well, this is a patient that had an extended depth of focus lens. She had had a DSEK in the past, and the DSEK was failing, so we thought, well, maybe let's try and give her the best vision potential. So here I'm using the Sinskey hook to kind of release the DSEK graft 360, and then we pull it out the main incision. I didn't use any OVD, I just used an AC maintainer. And I wanted to see the level of the desmetorexis because I didn't do the desmetorexis. And so I used air, which is the best contrast, to kind of tell me whether the desmetorexis was big enough. So I wanted to see that it was at least 8 millimeters because I was using a 775 graft. And so once I inject it, I move it perpendicularly, and then I'm decompressing. I'm realizing that the graft was upside down, so I flipped it. And then I want to move it into the proper position before I try to unfold it. So you want to try and center that before you try and unfold it. Sometimes when you put the suture in first, that'll keep you from unfolding, but I see that S mark. I'm going to estimate how it's going to unfold, and then I'm going to do the Jerusalem technique where you kind of pin it down and then unfold the carpet. So it's like a carpet roll technique. So here we're just going to take these are 2 solder cannulas, and then just unfold that gently. I know Dr. Kim has made a point in the past to use the elbow of the 25 gauge cannula, and that's probably better because if you have fragile epithelium, you could be like nicking into it. So that's a good technique also. And then I have it nice and centered. So this is on a TB syringe that I'm going in, and I'm just going to do a little air bubble here, just a little bit. I'm at the pupillary margin, but I go slowly. Then I'm going to come out, and then I'm going to go towards the side like I'm hydrating my main incision, but with air. And then you can get that really tight fill. With DMEK, you don't have to be as highly pressurized as you do with DISA because it's more about surface tension. But I leave it like that for about 10 minutes, and then I'll bring it down so that the bubble is right at the meniscus of the PI that I previously made. So this was a case, it's not that common where you're going to want to replace a DSEK with a DMEK, but because of the EDOF lens, I thought that that would be a good procedure for her. All right.
Great case. A lot of pearls there, Nicole.
Yeah.
So with that video still up there, Dr. Fram, what size air or gas, we'll use interchangeable, do you like to leave at the end of your DMEK procedure?
So I always want, I mean, I'll do like 80% or even 90% air or gas. I used to only use air. Now I use 16% SF6. And I want, the key is that you make your inferior PI and you want to see the meniscus at the border of the inferior PI so that you know that the PI is going to be working with some aqueous to move fluid back and forth. That's the key. So that's what helps me. I know some people just dilate the pupil and then they, you know, just like they do with DSEK and leave an 80% bubble. But I found that that worked for me well, and I haven't had a lot of pupillary block. I'm the only one that does the gas dilution. I don't let anyone else do it for me. So I think that's also an important point because there are some, you know, anecdotal reports of, you know, it expanding. And so if you should be the one as the surgeon to always dilute the SF6 if you're using gas.
Dr. Yu or Kim, any other comments on the air or gas bubble size at the end of your procedure?
Well, I think one of the mistakes I made, sorry, Liz, is when I was first doing DMEK, I was just over pressurizing that anterior chamber. Like in DSEK, you really want a high pressure. I mean, I want pressure 40 to 50 for 7 to 8 minutes because I want that stroma to stroma adhesion to occur in DSEK. But DMEK is very different. And I think Jose Guel is the one who told me, he's like, because I was noticing that my DMEK grafts were detaching. I mean, not small detachments, large attachments. I think I was just knocking out endothelial function with that high pressure, because it's very different from DSEK. I want a pressure around 10 to 15, pretty soft, and I'll touch it with a dry Wexel sponge so that is soft when I have that, which I aim for about a 90% fill with the SF6 gas, 20%. I only wait 3 to 4 minutes, so it's half the time that I do for DSEK. And afterwards, I do have them lay flat in the post-op holding area for 30 minutes. We check a pressure, have the patient sit up to make sure that the meniscus of the bubble is above the PI.
I'll be honest, I mean, I've become so comfortable with knowing that if I'm controlling the gas and I know my PI is very peripheral because I did a laser PI before and my bubble had cleared it, I don't even check it at the slit lamp anymore because it's gonna be okay. You know, the patient, if they don't feel great or if they're nauseated, then I have them sit up or turn to their side and I give them all those instructions. But similar to DSEK, at first I was checking, and after about 30, 40 cases where I wasn't seeing any weird pupillary block or really high pressures, then same thing in my DMEK experience. I'm not doing that check. The IOP check, yes, but I'm not checking at the slit lamp anymore.
And we don't either. We just do it.
Okay.
Yeah, we just have them sit up. We just have them
Yeah.
sit up, and you can visually see that you'll have a meniscus from the bubble. We want to make sure it's covering the PI.
Okay, so I'm not being rogue like cowboy style, because I know a lot of surgeons who are still very particular about
I
looking
used
at
to
them
bring
at the
a
slit lamp.
portable slit lamp. I used to bring, I had like a little
I
kit.
mean, we did everything, right? Just to make sure. But it's become, I mean, and you realize that, they do really well because we do leave their pressures a little bit lower at the end and such.
I had a feeling these questions would start after we brought up this air maintenance, and it has begun. Air versus gas.
Oh.
A couple of different questions. I'll kind of word them two different ways for our panel here tonight. Number one, is SF6 gas necessary if many colleagues suggest air works just as well? And then the next question, kind of in combination, is how do you decide air versus gas? I first should maybe start by saying, is anyone using air on this panel?
Not for DMEK.
Not for DMEK.
Dr. Fram, what are your thoughts on air versus gas?
Mike Strako and Mark Terry looked at this, and they published on it and found that their rates of detachment went down significantly when they started using gas. So I was having a significant amount of detachments with air. And when I switched to gas, it just is not as common.
Correct. I agree. I mean, I actually never even did air with DMEK. Just went straight to 20% SF6 gas. And I know it is a little bit of a hassle in terms of maybe accessing or getting it. We obviously, most academic centers will have it in the OR because the retina specialists use it. And I actually do have the nurses mix it. I don't mix it myself, but they, we go through an instruction thing to show them how to mix it to make sure they dilute it correctly. So, with DMEK, I think, if you start DMEK, you're going to have some detachments, but usually they're peripheral and they're limited. And there's a scenario where I will, inject with air if it's in the clinic. Right. Typically, I see my patients post-op day 1, but post-op day 1, they're going to have a pretty large bubble. You're not going to see a detachment, but I see them back at 2 weeks after. That's my next visit. And by then, you can clearly see if you have a detachment. And I have a pretty low threshold for taking them to the minor OR and just, filling their chamber with air again to make sure that those peripheral detachments are flattened out.
Another question to throw in there, how many rebubbles is your threshold before just electing to go back and do another DMEK procedure with a new DMEK donor tissue?
I'm 1 rebubble, and if my 1 rebubble shows that as the bubble goes away, it's a smaller detachment, I feel good saying, okay, maybe just a little bit more air and time, because if it's 25% or less of a detachment, oftentimes, if it's not involving the center, I mean, I just had this where the patient's central cornea is 578 microns at 2 weeks out, vision is 20/40, and there's like a wedge of a detachment. And I know that's going to clear, and I know that'll be okay. But if it is 1 rebubble and it still detaches pretty much the same amount and sometimes even more, then I know it's just, I'm going to go in and I'm going to redo their surgery.
And what was that,
really,
Dr. You just mentioned?
What was what?
What percentage of the graft you just mentioned?
About no more than 1/5 to 1/4 of the graft. Yeah.
I think that's an excellent point to bring up. When you see these patients, and if they do have a peripheral detachment that's small and it's not affecting their central vision, you can leave those alone, and they'll sometimes spontaneously reattach. Sometimes they won't, and you'll just have some endothelial regeneration in that area, and you may not have it'll just fibrose a little bit, but it's not gonna. They're not gonna notice, and it won't hurt them. But I will say 90% of the detachments get addressed with a single bubble at one time. I tell you though, I have 10% of patients where I've done more than one, and my limit is 3. And I think it's also, you need to base it on how the rest of that corneal is doing. If the graft looks okay, it's just that one area, then I will try rebubbling max 3 times. And it's interesting, when you give the patients the option, they will much rather go with the rebubble than they will going back into the OR for a repeat DMEK graft. Again, assuming that the majority of the graft is functional and doing okay.
I think that it's a great point, but I also feel like this is where you need to be really honest as a surgeon, right? So if you were in there and you were putting a lot of BSS and you had to flip it a bunch of times, or it shot out of the eye and you put it back in, not that I know anyone who's ever done that, I think it's really important that you're honest with yourself and honest with the patient. And that will help also dictate how many rebubbles you're comfortable with.
But those are the cases that you know are probably not even going to do great with a single rebubble. You know, the cornea looks pretty edematous diffusely. You may try one bubble, but they're not going to clear. Those are not the ones that I think that are going to do well with a second or third rebubble if the rest of the cornea is really not doing well yet.
Gotcha. Well, thank you, Dr. Yu, Dr. Kim, and Dr. Fram. We can't thank you enough for sharing your incredible wealth of knowledge and experience with us today. As always, you guys are so easy to work with and really add value to each other's responses. We really appreciate that. In a moment, we'll present our panel with the remaining questions you provided during the broadcast. If you haven't already, please submit your questions now. You can do this by clicking on the tab that says questions in the right box in the upper right-hand corner of your screen. When you click the plus sign, this will open up a text box for you to write and send your questions in. And thank you to those who have kept me busy this evening. So let's get to a few of those questions that are coming in live. And I'm actually going to disappear again, unfortunately, so I can get through these as quickly as possible. But Dr. Fram, I actually wanted to go back to you as you provided a great video on a DMEK under a DSEK. But this question is, what pearls do you have for a DMEK under a PK?
Just to clarify, I took out the DSEK and then did a DMEK. But a DMEK under a PKP is not that hard. You undersize it a little bit. Sometimes you don't even have to take Decimase or anything. You just leave it there. And so I find that those cases work out really well. You just have to have the right amount of visualization, and that can be tough. So you have to take off the epithelium so that you can really see where you are, and you want to make sure you have a good trypan stain on your graft. So if you have an 8mm graft, order a 7.5. And then you don't really have to do desmetorexis under the PKP unless you feel like you can get really good visualization there.
I think I just want to chime in here. I mean, I don't think the technique is that difficult, but Nicole's right. A lot of these failed grafts have pretty, swollen corneas that have difficult visualization. So, typically these are patients who have probably some limited vision from their regular astigmatism, refractive error, et cetera. So why make life difficult? You can do a DSEK with an ultra or nanothin graft and have an excellent result.
Yeah.
I would agree. I mean, that's what I do generally. I'm always concerned, especially when I see, because the suture sites and everything, I mean, you don't know how level and smooth that peripheral tissue is. I undersize my DSEK tissue too. I know some people will oversize it to the PK. I prefer undersizing it. And obviously, if this was somebody who had good vision potential, where I'd like to keep their PK intact and not swap their PK for another full thickness, but I preferentially will try to make my life easier with a DSEK.
So this question is neovascularization and cornea grafts. What do you do to prepare the patient? Do you treat the neo? How?
Is it so? There's a difference between kind of superficial neovascularization and then deep stromal neovascularization, both of which it's in your best interest to treat for a while with some topical steroids to try and get that to regress, in my experience. But that's a sign that the patient may have interstitial keratitis, HSV, things like that, and you want to think about keeping them on Valtrex or acyclovir for prophylaxis.
Actually, I learned my neo from Terry because of the topical Avastin and everything. So do you still do some of that, Terry?
Yeah, the topical Avastin, it works, but it's just expensive to formulate as a drop. Yeah, so
yeah.
I mean, what usually is more important reported is subconj injection of bevacizumab or Avastin, particularly if you have an area, as Nicole mentioned, that is like deep angry neovascularization, and maybe it's in the quadrant that you want to make your incision. There, I think it may be worth trying a shot of subconj Avastin to see in addition to your topical corticosteroid.
I do the same thing, and I'll do it pre-op, especially when you know it's sectoral. So you know that this person, especially when there's lipid keratopathy or whatnot, and you're doing this pre-operatively, I will do like a series of 3 rounds, but I actually transect the, with my 30 gauge or 27 gauge needle, I'll transect that conjunctival feeder that's going in towards the cornea, because all these anti-VEGFs, they work better for weak neo versus well-established kind of thicker vessels. And then it does take a little bit of time, but it really is a great feeling when you can either argon laser it or not, but just do a series of that and then see how they do regress with the topical steroid plus that. But it's staged and takes a few months. Otherwise, if it's diffuse, it's more limbal stem cell deficiency, and that's another kind of separate issue to manage first.
Absolutely. So guys, we're coming up on the hour here, and I'm going to try to rapid fire these questions as quickly as possible so we can get through as many as we can. Dr. Fram, how long do you immunosuppress after DMEK?
So I do topical steroids 4 times a day for a month, 3 times a day for a month, twice a day for a month, once a day for a month. And then I keep them on a maintenance of lodiprednol or low dose steroid based on work that's been shown that it decreases your rejection rate from 6% to 1% when they're just on 1 drop of a low dose steroid.
Awesome. Dr. Kim, what do you typically target for DMEK CE-IOL?
Typically, I mean, Frank Price and others have shown that you probably have about half a diopter of hyperopic shift. So I will shoot somewhere between, a quarter to a half for my DMEK triples, assuming that we're aiming for distance or plane of vision there.
Dr. Yu, you mentioned that you give it 1 rebubble and you're back to the OR, but I actually really like this question because I think it's pretty gray. When do you consider a poorly attaching graft a primary graft failure? And really for the entire panel, is there a clear definition for PGF in DMEK?
Great question. I think Terry and Nicole mentioned it earlier, but it's you've got to be honest with yourself as a surgeon. If you know that it was a pretty timely surgery, it wasn't too traumatic, and you notice that after 1 rebubble, it's really not sticking well, and there's kind of bare detergescence that's occurring, even if it does stick. I would say that that's the consideration for primary graft failure versus a traumatic surgery and loss of endothelial cells as a result.
And another quick question, I guess I'll throw this back to Dr. Kim. How long do you wait to rebubble if the graft has not cleared?
Usually I'm seeing the patients, like I said, post-op day 1, and then at that 2-week visit. And then I can clearly see. So usually they're waiting 2 weeks before I rebubble them, because I usually rebubble them right there and then. Unless, like I said, it's a small peripheral detachment that's in the periphery and not affecting their vision. So I do base it a lot on the degree of edema and if they're visually symptomatic from it.
Dr. Fram, this next topic was discussed in a little bit more in detail in our second advanced DMEK webinar. So what I suggest our participants that haven't got a chance to check out a much longer explanation, but just some high-level management of a floppy iris in DMEK.
Yeah, so, you need to be able to get the tissue into the eye without disinserting the iris. So in that video, what I showed is just putting a paracentesis right under your main incision and just putting a flexible grease hopper iris hook under there gently so that you can get the tissue into the eye. You move the tissue perpendicular to the incision, and then you can remove the iris hook and then do your tap techniques. So, and then be careful to not overpressurize. So overpressurizing the eye in a floppy iris and changing the fluidics where air gets behind the iris is not going to work in your favor. So really paying attention to the fluidics in these eyes is critical.
Dr. Kim, again, we went into a little bit more detail in the very first advanced DMEK webinar, and you guys did such a good job. We asked you for part 2 and 3, but really simply, DMEK after post-vitrectomy, do you do it or just go with DSEK?
Well, I would recommend that you get quite a few cases under your belt before you do the post-vitrectomized eye with DMEK. And the main issue is trying to shallow that chamber. Mike Strako has a great video where, you apply digital pressure to the equator of the globe to prolapse that iris forward so that you'll have a shallower chamber. But sometimes in these post-vitrectomized eyes, especially if they've had a complete vitrectomy, there's nothing in there in terms of substrate to push that iris forward. And I've had cases where I've actually, with my fellow, so we've had 2 fingers pushing this eye, probably causing iatrogenic kissing choroidals, but we're able to shallow the chamber enough to get that DMEK graft to open. And those are the cases where, you really want to just, if your DMEK graft is unfolded and it's fairly centered, just go ahead and inject your eye with gas and get out, because those are very, very difficult cases. So I would say just make sure you have experience with DMEK grafts in different scenarios before you move to that scenario, or just go ahead and just convert them, to a DSEK.
Thank you, Dr. Kim. And I think we have time for one more quick rapid fire question. Dr. Yu, again, I believe we went through this a little bit more in the first webinar. However, DMEK with tubes, thoughts, pearls? You can phone a friend for Dr. Fram.
Actually, in the right setting, it's not as bad because it almost traps it so it can't get too far. But the problem is the sizing of the graft itself. You always have to go a bit smaller, regardless DSEK or DMEK, simply because of the tube itself. If it's a really well-functioning tube and the IOP is pretty low, then I'm gonna go with a DSEK, because I'm just concerned about the even gas staying and being maintained in the eye after the surgery. But when it's complex, any graft tissue can have a greater chance of failing, and it's like upwards of 25% within 5 years whenever you have any AC hardware. So if it is relatively straightforward, I'll do DMEK, but otherwise I will 75% of the time go with DSEK.
Absolutely. Well, thank you guys again. And we have more and more questions rolling through. Again, I do want to put a plug in for Advanced DMEK webinar part 1 and part 2, as a few more of these questions we just haven't had time to get to tonight are really thoroughly discussed in those first 2 Advanced DMEK webinars, dealing with fibrin with DMEK, myopic or really deep ACs, and so forth and so on. So again, Dr. Yu, Dr. Fram, and even Terry Kim, we really appreciate your time and a terrific job again this evening.
Thank you, JD. Thanks to Corneagen as well.
I have a little bit more. Thanks, Dr. Kim. Please know that CorneaGen can further help you get started on DMEK or to work through some of these complicated cases. Please contact us at info@corneagen.com, and one of our surgical product specialists can provide you with support, tissue, and tools for DMEK training, including a one-on-one wet lab. Following tonight's session, we will be emailing you a link to access the recording of today's course and a survey soliciting your feedback. We ask that you do take a few minutes to complete the survey, as your comments will help guide us in presenting the best possible educational webinars in the future. So, Dr. Kim, Dr. Fram, Dr. Yu, you must have had great surveys, because this was part 3. Many thanks to each of you again. I would like to say thanks to everyone for participating this evening. Enjoy the rest of your evening and have a great night.
Thanks, guys.
Bye, everyone. Thank you.
Good night, everyone.